welcome to the audio lecture for chapter 16 and 17. This one is going to be very short. I'm just going to kind of briefly go over the notes a little bit. I'm going to talk a little bit about tertiary care. So with tertiary care, you know that it's the third level in the levels of prevention. When a patient gets to this level, they require more devices or something a little bit more extensive for treating their diagnosis or their issue. Basically, tertiary care is all about restoration and rehabilitation. With tertiary care, there is a great need for AHC. These are the American Health Centers. Okay, they are the primary facilities that are associated with tertiary care. So who provides the tertiary care? You have your academic health centers, your specialty hospitals, and then you have, believe it or not, you have a lot of research and teaching hospitals that provide tertiary care. So some of those services are things such as physical therapy, speech therapy, respiratory therapy, durable medical equipment. So most private health insurance policy payers usually pay for their tertiary services. About the only services they probably won't pay for would be anything that's a surgery or a therapy. And it's usually because most private payers consider a lot of those surgeries and therapies as being experiments or experiment things, so they don't feel obligated to have to pay for those services. All right. Chapter 17 talks about palliative care. So now you know palliative care is designed to keep patients comfortable, not designed to keep patients alive. It's just to give them that reassurance or that ability to live out their last few days, a few hours, or a few months here on earth. So in that facility, patients are usually getting something for pain and something just to keep them comfortable. So palliative care is the end of life, regardless of a person's age. Okay. And again, they are in no way of trying to keep the patient alive. Now, where can palliative care occur? It can be that individuals come to your home. It may be in freestanding hospice places, or it also might be in a hospice facility that's associated with the hospital. All right, you have your hospice care. Hospice care is basically designed to ease the pain and stress of terminally ill patients. Again, their job is not to keep, they're not trying to keep the patient alive, they're just trying to keep the patient comfortable. Hospital care services have a variety of services within that department, like pain management, prescription drugs, short-term hospitalization, psychological counseling, etc. You have your occupational and speech services. You have physical services associated with hospice. So again, those things that I name are not there trying to keep the patient alive. It's just mainly just trying to, let the patient enjoy him or herself and give them a little, there to give them some hope. There to give them hope, talk with them, basically just kind of let them have what they want to have, say whatever they want to say, because they have a terminally ill disease or condition. So they pretty much know the outcome and things of that nature, but just being able to, spend their time with your loved ones and things of that nature. Accessing hospice care is pretty much like any other thing that you're trying to access for as healthcare services. Usually when we talk about hospice care patients, I do want to make mention that these are usually those that have a life expectancy of less than like 6 months. So hospice care usually requires a physician certification or pre-op, pre-cert. Okay, so basically a doctor has to sign off paperwork that says yes, he or she is a terminally ill patient and require hospice care. So what are some issues that are surrounding palliative care? One of those issues is potentially ineffective care, because what you want to make sure is that even though those individuals have a terminally ill condition, you still want to make sure that you provide the utmost care to those patients and that you don't give them what you call ineffective care. Physician-assisted suicide is on the rise or on the increase because a lot of physicians feel compelled, they want to help their patients go ahead and end life because they're suffering, they're tired of suffering. So again, physician-assisted suicide is on the rise.